Thank you very much. It's terrific. And for time reasons, we're going to progress forward. And our next speaker comes to us from the UK, is Dr. Susan Young, who's a senior lecturer in the Forensic Clinical Psychology Unit in the Department of Forensic Mental Health Services, a program leader, and is a senior lecturer at the Institute of Psychiatry at King's College. And she'll be speaking about psychotherapy for youths and adults with ADHD.
Hello. As before, we have a little bit of housekeeping here with some of our standard slides. I'm going to be showing you a video, and I just want to point out that I do have permission from the participants to show you this video. But I want to start by thinking about the pathway from children to adulthood for people with ADHD. It's not an easy pathway. ADHD is not a disorder that's just solely limited to childhood. By the time young people often reach their adult years, many will retain a full complement of symptoms. Others, as they grow up, will remit some of their symptoms. Some people, though, will still have some symptoms that are disabling by the time they reach adulthood. Others have what I call a graduates. That they've recovered from their symptoms, they've remitted from their symptoms, but they have what we call, my colleague and I, Jessica Bramman, at the Morsey, we call it the hangover, a hangover of kind of ADHD baggage that affects just about their whole life, everything they do, everything they see. It's almost like they put on grey-coloured spectacles. This is hardly surprising, given that they've often experienced a lifetime of negative reinforcement. They've failed academically, they've not got on with their peers in the schoolyard, they've got occupational problems, they may have difficulty holding down a job. They feel that they're different to many of their siblings, and they're evaluated differently by their families. Conduct problems become antisocial problems, become delinquency, and sadly for some, this is a route into crime. Interpersonal relationship problems start at school. They go on with their friendships outside of school, intimate relationships, disruptions of family relationships. There are many studies that will tell us all about this. At the same time, in the transition, especially between childhood and adulthood, they're having to regulate their emotions. They have this ability of mood that they have to cope with. Swings of mood state, feelings of anger, feeling low in mood, frustration, feelings of anxiety. This impacts on their personal resources. They often by adulthood have developed personality characteristics that some people call disorder. They've developed often a learned helplessness, internalized failure, low self-esteem. They expect to fail because they've always failed, and they expect other people to see them to fail. The one thing that I've heard over and over again by clients that I've treated psychologically for ADHD is that they all feel that they've underdeveloped to their potential. ADHD is a heterogeneous disorder. It's experienced very differently by many people. But the one thing that seems to be common is this feeling that that they haven't achieved and can't achieve their potential. So as they grow older, their needs change, and their treatment needs change. We know the MTA study suggested that behavioural treatment isn't very additive over and above medication. Perhaps cognitive treatment would be more successful, particularly as young people grow up and they're much more able to take full advantage of the cognitive model. Remember, adults need to learn to impose structure on their time. As children, they have a lot of structure imposed for them at school, by their families, hopefully. But a young adult who doesn't live at home, who hasn't done very well at school, who can't hold down a job, who's living in a bedsit somewhere, needs to learn to structure time themselves. They need to learn to develop coping strategies also to cope with life's failures. What about medicating them? Well, half of the studies suggest that medicating adults, they're just non-responders. It doesn't help at all. For those that are helped with medication, they suggest that it's not that successful. So I'd like you to think in our voting slide whether adults have a greater need, do you think, than children, and young adults have a greater need than children for psychological techniques to learn strategies and skills for coping with functional impairments. Can you vote now, please? Yes. Well, I'm very pleased to see that you agree with me. Forward way. Does it move straight on to the next slide? Oh, thank you. Well, what do we know about young people who are growing up into adulthood? We know that even when they're diagnosed as children with ADHD, that they have multiple presentations to adult mental health services. The follow-up of the 208 Danes treated with stimulants showed that almost a quarter had a psychiatric admission in adulthood. This was a mean of 2 admissions. But look at the range of admissions. It ranged from 1 to 36. The most prevalent reason was for a diagnosis of personality disorder and mood disorder. This is the second reason. Most of the personality disorders were because of antisocial personality disorder. Childhood conduct problems were predictive with a hazard ratio of over 2. Girls had a greater risk than boys, especially for mood disorder. Interestingly, 2 males died in the follow-up period, one of suicide and the other of an accidental overdose. So, my colleague Jessica Bramman and I, from the Maudsley Hospital, we wanted to ask our patients, what does it feel like what is your experience of being diagnosed as an adult for the first time with ADHD, as a young adult, and treated with medication? What they told us is that they initially went through a review of the past when they thought about how they differed from others. The diagnosis gave them a cognitive framework with which to sort of think about their experiences that they've had to date. They then described going through an emotional turmoil, an emotional impact of set stages following receiving the diagnosis. This ended up with them thinking a lot about their future as a person with ADHD, the realization and recognition that this is going to be something that was going to be with them for some time. They outlined a 6-stage model of psychological acceptance. Initially starting with feelings of relief and elation, thank goodness somebody's recognized my problems, followed by feelings of confusion, emotional turmoil, thinking back to the past, feelings of anger, a lot of anger, feeling very angry that they'd presented at in front of numerous professionals. They've told their story over and over again so many times, and nobody had recognized the problem. They felt sad. They grieved almost for lost possibilities and lost opportunities, feeling if they'd been treated before, then maybe life would be different. They then felt very anxious about the future. How long do I have to be taking medication? This then moved into a period of accommodation and acceptance of the disorder. We asked their partners as well what their perspective had been in supporting the ADHD clients through this process. First of all, they told us an awful lot of complaints about the general inadequacy they perceived in the partner. And it was all about, he falls out with his mother, or she rows with the children. He decided to redo the kitchen and he hasn't replumbed the sink, and I've been without a sink all week. There are all sorts of complaints about unfinished tasks and the kind of a general inadequacy. They then also themselves underwent a sort of emotional process that paralleled that of their partners. In particular, they were talking about how they themselves started to read about ADHD, find out about it, and then wondered, really, can I stay with this person? Can I help this person? Can I support this person through this? What does this mean for me as a partner of somebody with ADHD? Is it ever going to get better? There was a lot of hope put into medication, and then a lot of disappointment with medication, because it didn't resolve all the problems. So we felt that the process of acceptance model indicated a very important role for psychological treatment to help and support individuals through this process. We also know from the What Works literature that comorbid and associated problems are also amenable to psychological treatment, like anxiety. What needs to be done, however, is adaptations need to be made to the treatment in order to make it appropriate for people with ADHD. They've got to learn listening skills. They've got to learn to finish tasks. You need to introduce far more rewards and on a more frequent basis, for example, to keep them focused on the treatment. We then thought, yes, but what is the evidence for psychological treatment in adults? Well, I can't stand up here and give you loads and loads of data because there isn't any. Individual treatment, there's one RCT, randomized controlled trial, which compared a CBT and a medication group against a pure medication group. They found significant improvement in symptoms, anxiety and depression, and this was supported by independent ratings made by clinicians. In terms of group treatments, there's a few very small group treatments that show that this is very helpful, but these are very small studies and they didn't use any controls. So, working blind, as it were, my colleague Jessica Bramham and I, we wrote the Young Bramham Programme. It's published by Wiley, and what we did, though, was we integrated techniques from psychoeducation, motivational interviewing, CBT, and cognitive remediation therapy. We also made adaptations to make this programme specifically effective for people with ADHD in terms of the style of delivery, the rewards, lots of small exercises that can be downloaded from the companion website. It can be delivered on an individual basis or in group therapy, and it works on a modular basis. So individuals, you can assess the patients and then see what they need by selecting modules, like in a pick and mix kind of style. So it talks about the assessment, it talks about how to treat core symptoms, and with that we included time management, problem solving, impulsivity. We drew on what we knew and what our patients had told us about what their needs were and how they needed support. We added cognitive behavioural treatments for social relationships, anxiety, frustration and anger, low mood, depression, sleep problems, sleep disturbance. That was one of the things that our clients were asking us for advice about, and substance misuse. And importantly, because we listened to the process of acceptance model, we included a whole section on how to prepare for the future, thinking about the future. We've evaluated it. The Maudsley is a national clinic, so people come from all over the country to the clinic. So we couldn't do, group workshops, one a week for 12 weeks or something. So group sessions, I mean. So what we did was we put together 3 one-day workshops, and clients came every month, once a month for 3 months. We used all sorts of different techniques to teach, showing PowerPoint group discussions and what have you, and role play. We took 61 people, we've taken through the group, who are in the CBT treatment group, who are also on medication, and compared them with 37 waiting list controls who had treatment as usual. And we succeeded in our aims. Remember, it's a brief, intensive piece of therapy. It was just 3 days, but the CBT group showed significant improvement in their knowledge about ADHD and raising their self-esteem and improving their self-efficacy. So they came out of there, having gone through this process of being diagnosed and feeling very anxious and worried about the future, to feeling, yes, that the future may hold something that I can do, that I can achieve in. Interestingly, both groups showed improvement in symptoms of anxiety and depression. So just treating them with medication improved their anxious feelings and their feelings of low mood. Now, I have here a video that I'm going to show you that gives an example of what we would do in the session, working with the clients in the social relationships module. You'll note right at the beginning that one of the clients has sort of drifted off, he's not paying attention, so when it comes to starting the role play, he has absolutely no idea what to do. This time, I want two people to role play, having two old friends who haven't seen each other for a very long time, yeah? You're really pleased to bump into each other at a party. One of you, though, has come into the party and is just butting in on the conversation all the time. Just won't take the hint that this person isn't wanted in the conversation. Won't take the hint that you really want them to go. So the other's got to be really kind of irritated and butting in. And so, who do you think? Who feels they can take that role?
I can butt in.
Can you butt in? Okay. Okay, so it's you two, the old mates who met up at a party, you haven't seen each
We've known her for a little while.
Because I went to school with her, you see, so obviously we're really close.
Yeah, we went to school together.
You
trying to catch up.
Lovely.
Yeah.
How long has it been since you've seen each other?
Well, we were just trying to find that out.
Okay, so sorry, go ahead, let's stop you.
Do you still see, what's his name again?
Which school did you go to the same secondary school afterwards, you two, or because I was at primary school with her?
Oh, I didn't go to school with her.
Oh, you did?
No.
Just, yeah. Okay.
No, I don't actually know that well.
Yes. Sorry, what were you saying, Jude?
Oh, what was his name? You know the one that was in our class?
Did you say the bathroom was over there in that school?
Yeah, bathroom's over there. If you want to ask somebody about food, they're there. And yeah, we know Louise because we went to school with her. Thank you.
That was very good. Well done. Very good, all of you. How did it feel to have someone butting in all the time?
I didn't know what it was for 10 minutes went back.
Perfection.
Budding career.
Budding in career.
I just felt like something oil and I was just like, for God's sake.
I actually didn't really say anything. Every time I opened my mouth, the noise would come from here.
And so how was that making you feel?
Actually, at one point I almost got totally cut out, like altogether. So, yeah, I don't know, I mean, it was quite frustrating, I mean, because I literally couldn't respond. Like, every time there was a pause in the conversation, straight in.
That's like, but you actually asserted yourself at the end. I mean, you had to assert yourself and say, look, the toilet's here. The people, if you want to know where the food are there. He summarised it, didn't he? And he pointed it all out and made it very sort of clear. But you just weren't picking up on any of the cues. What cues were they giving?
They weren't engaging with me. They weren't asking me anything.
What else was showing a no entry sign here?
They kept trying to look at each
Body
other.
language.
They weren't. Yeah, body language. June actually was completely trying to cut you off.
Oh no. Oh, thank you. Okay. Of course, though, this is something that we're doing for people kind of at a clinic. The question for me, I work in forensic services now, is do we need to provide something different for offenders or people who are on the trajectory towards offending, something different, people who also have ADHD. We know from the 30-year British cohort study, the follow-up, that both males and females are at risk of police contact for minor offending, but males have greater contact with police or courts as a persistent offender. We've known for a long time that court records have shown that youths are up to 5 times more likely to be arrested, and that there are going to be multiple arrests and convictions. Prison studies have started to come out from all over the world now that suggest that up to 2/3 of inmates have childhood ADHD. Some of them suggest up another 30% had adult symptoms and 16% in partial remission. Now, these are probably overly inclusive and they're based on screening measures. So rates will differ according to what screens and what cut-offs are used. However, they are very high, much higher than what the rates that are reported in the normal population. And the rates are most likely to be higher, though, as well, in youth offending institutions. My colleagues and I have been doing a study in Aberdeen Prison. There we've used a more stringent screening procedure using the DSM-4 checklist of symptoms, looking first for screening for childhood symptoms and then again for adult symptoms. This paper is currently in submission, but what we found is that our screens, we've got more conservative estimates, which reflects the more stringent criteria we've used, but the screens suggest that approximately a quarter have a childhood history of consistent with ADHD. Of that group, around half were no longer symptomatic, a quarter were fully symptomatic, and the rest partially remitting from their symptoms. We wanted to take it one step further and look to see what rates of functional impairment there were present in these groups. So we went into the prison critical incident records and looked at everybody who was in the top 10% of critical incidents. We compared the data for the symptom groups compared to the non-symptom groups, and what we found was a significant difference. So these people, even if they're in partial remission of their symptoms, are causing a problem within the systems. If we in the UK extrapolate from this Aberdeen data, it means that we have 17,000 male prison inmates with a childhood history, possibly, of ADHD. It also means that we have 10,000 who are symptomatic, including being in partial remission of their symptoms. Now again, I will say these are probably overly inclusive because they're based on screens, but what it does mean is that we have 10,000 people in our system in the United Kingdom who perhaps would warrant a closer look to see whether they can be supported or helped better. And remember, these people are kicking up and causing more problems, higher rates of critical incidents in the prisons, possibly. And what this means is that they'll stay in longer. Higher rates are probably likely to be in youth offending institutions, as I said. So, in terms of vulnerability, I think it's important to consider this because I think that people with ADHD are vulnerable in the criminal justice system. They're vulnerable, first of all, because they get caught. They're not good criminals. They do not notice that they're engaging in unplanned, opportunistic crimes, and they don't notice the CCTV camera in the corner recording what they're doing. They don't notice the security guards calling the police or locking the shop doors. So they get caught in the first place. Once they're apprehended, they then have to cope with the process of the criminal justice system, which can be very complicated. They might be thrown in a cell for some time and left there to kind of cool down. They then have to go through a police interview. They might have to review an awful lot of evidence. Youth will have an appropriate adult with them, and that appropriate adult is likely to be a parent who may well also have ADHD, who just says, tell the police officer everything that we need to, that he wants to know, and let's get out of here. They've got to attend court. They've got to be able to instruct their solicitors. They've got to be able to attend and pay attention and listen to the trial. As I said earlier, when incarcerated as well, especially undiagnosed and untreated individuals, there may be a management problem due to behaviour problems. Not one person in our Aberdeen study had been diagnosed with ADHD or had even been assessed. We know, though, that this is like by the time they get to adulthood, but antisocial behaviour does not start in adulthood. We know that there are markers way before they even get there, and we need to intervene early. So what do we do about it once we know? It's not enough to stand up and say, oh, these are the rates, there's this and that. We've got to do something about it. And I think that clinicians, psychiatrists are probably, understandably, very reluctant perhaps to think about stimulant medication in this population. I'm not a psychiatrist, so that's a point for discussion. However, there are programs and also to be actually a devil's advocate, let me just say, what would happen if we do give them more medication? Do we make them better criminals? Less impulsive, less inattentive? So there are pro-social competence programs that already exist. Some of you may have heard of the Reasoning and Rehabilitation Program, and this has been adapted, for example, for people with ADHD, specifically for youths and adults, used for age 13 plus. The good thing about this new program as well, it's a group program, is that it includes a coaching, mentoring system with it, where they will meet with their mentor or coach, or we call it a pal. They meet them in between the sessions, and the idea is that they will talk about the sessions with the coach to transfer the skills they've learned in the session to outside of the session, because it's no good people just turning up to a session and doing some treatment within the session and then leaving, and then it's all gone. Everything just stays in that room. They have to start applying what they have learned in the session outside and applying it to their everyday life. So, to conclude, people with ADHD across the lifespan are presenting over and over and over again to mental health services and, unfortunately, a subgroup also to prison services. This is a considerable cost to society. Medication is the mainstay treatment for ADHD, and I think that medication will also help manage symptoms and predispose the success of cognitive behavioural treatments once individuals are old enough to take advantage of these types of treatments. These people need to learn to develop. They need to develop coping skills, coping strategies. They need to develop skills, and most importantly, they need to learn to achieve, that they can achieve, and that they can change things around. Thank you.